Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Welcome to the Rapid Response Nurse Podcast. And if you're scratching your head and thinking, hang on, that's not Sarah's voice, you're absolutely right. This is Nurse Gwenny, and I'm doing a not so hostile takeover, a very gentle takeover of the Rapid Response Nurse Podcast. And my guest today is none other than Sarah Lorenzini, the Rapid Response Nurse herself. So welcome to your own podcast, Sarah.
Thanks for having me, Gwenny.
So guys, let me tell you how this came about. Several months ago, I've been on Sarah's podcast a couple of times, and we're internet friends. We talk to each other occasionally, and we have connected through being internet creators. And I've listened to several of her episodes, and I think Sarah is a phenomenal podcast host. And she has all of these experts on her podcast, and we get to learn so much. But Sarah has so much expertise and knowledge about running a rapid response nurse team, and she started her hospital's rapid response nurse from the ground up. And I feel like it's such a miss that we haven't gotten to hear from Sarah's expertise. And so I texted her and I said, hey girl, can I do a hostile takeover of your podcast? And she let me.
I don't know what I'm in for, but I trust you, Gwenny. Let's do this thing.
Okay, so let's start how you start most of your podcast. Let's ask the guests. So Sarah, give us a nutshell version of your journey in nursing and how have you gotten to where you are today?
Sure. All right. So I graduated nursing school at the ripe old age of 19. I thought going to nursing school, I would be like a pediatric nurse or like labor and delivery possibly, but I cried every peds clinical. Labor and delivery was not what I thought it was going to be. And I had a job in the ER as a nurse tech, and I ended up falling in love with caring for patients and families in crisis. So never saw myself as an ER nurse, but I definitely loved ER nursing. So right out of nursing school, I was in the ER. Very quickly became a preceptor and charge nurse in the ER. Again, didn't see myself as a leader, but everyone else thought that I should be, so I was charging. ER nursing was like the best job ever. You get to care for people on the worst day of their life and walk alongside them, and it was great. And I was like, you know what, though? I love teaching nursing as much as I love doing the actual job. Like, give me all the students. This is so fun. And so I went back to school to get my master's degree in nursing education. In grad school, every professor is like, if you want to be a good educator, you need to get a more well-rounded perspective of nursing. And I was like, really? I mean, the ER does all the things. But I took their advice and I went and worked in the CVICU, cardiac ICU. And the nerd in me just loved like the gadgets and the gizmos and all the pressure monitoring from all the different orifices. Like it was so cool. I loved walking people through their cardiac surgery recovery. So cardiac ICU was great. And then in grad school, I was asked to be on the rapid response team at the hospital I worked at the time. First, I was like, well, what is that, for one? And once they explained it, I was like, oh, that sounds like a perfect mix of all my favorite things. Yes, sign me up. So I was a rapid response nurse for a bit, and then I finally finished that darn master's degree. I was a nursing professor, which seemed like a really great job for being a mother of 5 kids. Nurse professor for a whopping 1 year. And I loved the students, and I loved the clinicals, and I loved the teaching, but I was like not quite ready for office hours and faculty meetings.
Oh, yeah.
And so then the nurse that was my charge nurse when I was a new grad had become the director of the ER. And he asked me to come back as the ER nurse educator. And I was like, oh, that sounds amazing. I get to do nursing education and also be like, elbow to elbow with the nurses, caring for sick people in the ER. So I was the ER nurse educator for 5 years. What a great job. And then COVID hit. And I saw on my staff just like sweating in the trenches in their PPE. And I wanted to be back at the bedside and not doing education. And so the hospital I work at now, rewind back to 2020. At the time, we did not have a dedicated rapid response team. So if there's an emergency on the med-surg floor or the cafeteria or wherever outside of the ER, they would have the ICU charge, leave the ICU, manage the emergency, then have to go back to the ICU. And that worked okay-ish until COVID. Now the whole hospital is sicker, the ICU is sicker, there's more emergencies, more patients crashing, more intubations that are happening outside of critical care. And so I went to the CNO directly, was like, y'all need a rapid response, like a dedicated rapid response team.
Yeah.
I made my pitch. I had to give a lot of data. Anyways, finally they said yes. They hired just me as the lone rapid response nurse. And I very quickly was able to prove the efficacy of the team, bring on more staff. And now we have a team of 12 rapid response nurses. We are a Beacon awarded team, which I'm so proud of. But I think the thing I'm most proud of is the culture that we've established in the hospital. We really work hard to shift the culture surrounding emergencies away from like, oh, I can't believe this happened. You had an emergency on your shift, more to like, okay, this is an opportunity for us to come together as a team. Anyways, I love rapid response nursing. I love leading my team. And my podcast. About 4 or 5 months into being a rapid response nurse, I was like kind of not complaining, but like just processing with my husband, like, oh, I love doing this work. I love being a rapid response nurse, but I miss being an educator. Like I try to educate at the bedside, but there's no time. Like there's the next emergency to go to. And he says almost casually, like, why don't you just start a podcast and you can do all the education you want? Which I laughed at because I am like the least tech savvy person you've ever met. Like my kids have had to show me how to use my iPhone. But, me and YouTube University, we figured it out. And I recorded a handful of episodes literally in a coat closet with like a $15 mic from Amazon. And surprisingly, people really liked having a podcast about rapid response scenarios. And the thing blew up and I loved making the content. I love supporting nurses, not just at my own hospital, but like across the globe. And that's how Rapid Response Run podcast came about. That was a lot of yapping. Did I answer your question?
Yes. Yeah, that's really great. Let's back up and I want to go through, I want to ask you a few questions about some of the things you said. What is a Beacon Award? Like, I know what a Daisy Award is, but outside of that, ER nurses never see awards. So I don't know what that is.
Oh, yes. Okay. So a Beacon Award is something that's given out by the AACN, the American Association of Critical Care Nurses. And usually it's an award that's given to a unit. So like the neuro ICU can apply for the Beacon Award. It is a very difficult application process. I think our application was 50 pages long. Not just like answering bullet point questions. It was like narrative, like writing of describing what your team does, the impact they've made. You have to produce a bunch of data and metrics to show that you actually are making an impact in your hospital. You're looking at everything from like quality metrics to also what is like the dynamic of your team, like your workplace environment. Is it hostile? Is it toxic? Or is it a good working environment? It's a lot of work. But to be honest, the process itself, like applying, like having to apply was like a whole year process for us. And we learned so much about our team, about our opportunities, things we can improve upon. And even in the application, we were like growing as a team. So yeah, we worked super hard. I think we applied like August and we didn't find out until the following, like, I don't remember, maybe September, like a whole year later that we were actually awarded it because they have this whole committee that just combs through your application and does research to make sure you are deserving of a Beacon Award. So
that's really cool. Well, congratulations.
It's a big freaking deal, especially for a rapid response team to get it. Yeah, thank you so much. Yeah, very, very, very proud of it.
So take us back to when you approached the CNO and you said, hey, y'all need a rapid response nurse team. So tell us about some of that data that you presented to them and why rapid response teams are so important for the health of a hospital.
Okay, so I'll back it up a little before that. Before I approached the CNO, I approached trusted colleagues who know admin because I'm a bedside person. I'm not a data person. I mean, I've had to become one, but I'm not naturally inclined in that way. So I was like, what do you think admin needs to hear for me to like have a convincing argument? And they're like, Sarah, just saying we need to do this is the right thing to do is never enough. You're going to have to produce some sort of data to show there's opportunities, that we're going to continue to have bad outcomes if you don't have this. And so I had to look at, pull retrospective data from how many rapid responses happened a year ago this time versus how many are happening now. I had the charge nurses in the ICU keep a log of how many hours they were away from their unit per shift to look at okay, clearly, they're away from the unit for 8 hours. We have no charge nurse for a 12-hour shift, 8 hours of that. We need to have someone that's doing just this, right? And then we were looking at how many patients were upgraded to ICU or PCU. That's a lot of cost for the hospital. It's way cheaper to care for a patient on the med-surg floor than in a critical care department.
Sure.
I had to look at, just so much data to show I know we've been doing, quote, just fine having the charge do this, but because we're pulling this charge nurse away, we're not having the opportunity to really be the best that we can be. I think we could reduce the amount of patients who are upgraded to ICU. We could reduce the amount of code blues in the hospital. And there's just so many things we can talk about. Plus, nurse retention is a big thing. And there is a big culture dynamic that no one talks about, in that if the ICU charge had to leave the ICU to come to the bedside, of course they're going to be rushed and trying to get back to their own unit, trying to wrap it up. Of course, they're going to be this isn't even an emergency, or what? Almost I get it. They're trying to lead their team back home. That's who they're loyal to. And so this quote unquote emergency on the med-surg floor does seem like lesser. So of course the bedside nurse feels that tension, and of course is concerned about calling next time. Additionally, they're thinking to themselves, well, should I even call? I hate to pull them away from sicker people in the ICU to come see my patient whose blood pressure is kind of questionable, but they're not on vasopressors yet. Should I even bother them for this? So basically, there's a lot less rapid responses, surprisingly, before we started our team. We doubled the amount of rapid responses, but we cut the amount of code blues in half. So I'm totally okay with that ratio.
That's a really impressive metric, that you doubled the number of rapid responses, but you halved the number of code blues. How quickly did that change happen?
About 6 months.
Wow.
When you track the data, it's actually cool to see on a spreadsheet, the amount of rapid response calls going up per month and the amount of code blues going down per month. And when they crossed, switched directions, it was about at the 6-month mark. So yeah, super proud of that data metric for sure. But I think it's not just now that I exist, lives are being saved. It really is the work that we put into not just responding to the emergency, but preventing it in the first place. When nurses feel empowered to speak up and advocate before we're anywhere close to a code blue, that's how we prevent the code blues from happening. It's not just wow, I've showed up and managed the code blue like a badass. It's well, isn't it actually cooler to prevent the code blue in the first place? I believe so. So people assume oh, you're a rapid response nurse. You must just run from code blue to code blue all day long. And honestly, I'll maybe get 1 code blue a week. That's not the bulk of what I'm doing. The bulk of what I'm doing is preventing the emergency, coming alongside the nurse, answering their questions, being a resource. So yes, I love the rapid response role. The educator in me loves being a rapid response nurse. The ADHD person in me loves rapid response nursing because it's never the same and there's always something new and challenging. And the nerd in me loves the critical thinking of trying to figure out, Sherlock Holmes, what is wrong with this patient and what can we do about it,
Yes. Yeah. So the rapid response team is essentially EMS inside the hospital, right? You're the one that's having to find those context clues that our paramedic colleagues pre-hospital, they are doing that in people's homes. You're doing it in the hospital. And there's so many kind of elements of what you're doing, of, catching the vibe from the primary nurse who's taking care of the patient, and gathering some history and some data from them, and looking at the patient and assessing them, and looking at context clues around the room. And that's really cool that you guys get to do that. So you talked about some of the quantitative data, that you doubled the number of rapid responses, but cut the number of code blues in half. But what's some of the qualitative data? What did you anticipate? You immediately started hearing from ICU nurses and the ICU charge nurses. Did you start getting feedback from them right away?
Yeah, they're thank God you're here. The ICU is blowing up, and we've had 7 rapid responses in the last 5 hours. I could have never gotten to all of those. I'm so glad you exist. But I think the qualitative data that had the most value and that made my heart the happiest was to hear from the bedside nurse, Yeah, I used to be afraid to call rapids. Like I didn't want to bother anybody. But now that you're here, I'm happy to call and like put a patient on your radar or like process things with you. Because sometimes I just don't know if this is actually an emergency or not. So thank you for being here because I didn't know this is something I should be worried about. So like the bedside nurses who were like, oh, I feel so much more supported knowing that you're here to answer questions and knowing that you're coming if my patient's crashing. That's the kind of thing that really warmed my heart. And from a admin side, they're like, oh, you mean, did you say nursing retention? $? Like that's what they hear. But what I hear is a nurse feels supported and a nurse feels empowered. Like, yes, that's why I love this job.
Oh, that's excellent. I love hearing that. So if there's another nurse that's listening who does not have a rapid response team at their hospital, how would you recommend that nurse make the argument to admin, and where do they even begin from the logistics side of it? And are there resources out there, experts that they can consult to help them start a rapid response program?
I think that it's important to know what your hospital is trying to do. Are there any quality metrics they're trying to get better at? For example, door to needle time. How are your inpatient strokes? How are your inpatient STEMI alerts? How is sepsis going for your hospital? And when you expect a bedside nurse who has 6 patients to manage an emergency by themselves, it's going to be hard to make impressive metrics in those areas. But if you can find ways to insert yourself as a rapid response team or as like, hey, we need a rapid response team to help with these things, I think you have a compelling argument for, as a rapid response nurse, I'm not like billing for things. I'm not making the hospital a bunch of money. I am saving the hospital money by preventing bad outcomes. Does that make sense?
Yeah.
And so if you can figure out what they want to get better at, what the issue is. If the issue is bedside nurses are leaving in droves because they don't feel safe, you're going to talk about that. If the issue is they're trying to meet a certain standard to be a comprehensive stroke center or a certified sepsis center, whatever the thing they're working on, I'm pretty sure you can find ways to get the rapid response to be a part of that process, to improve the process, to improve the numbers, but ultimately to improve patient outcomes. And that's the driver for me. So I'd say start there. Do some digging, ask some questions, pull some data to figure out what the opportunities are. And then when you go to make this ask, the second you say staffing or FTEs or bodies, it's like admin's like, oh, I've heard this before, So you have to like word it a little bit differently so that they hear like risk mitigation or safety improvement, quality outcome promotion. I mean, this is not my expertise. I have to like rehearse ahead of time to like use that verbiage. That's not how I talk. Grandma needs an experienced clinician to come to the bedside for these emergencies. The patients deserve to have someone who feels whatever. That's what I feel like I want to say, but I have to admin speak for it to be effective.
Yeah, that's really wise that you would say that because it's almost like a psychology experiment that you have to figure out what matters to admin, whether it's they're trying to improve their sepsis numbers or they're trying to prevent all of these CHF bounce backs coming back to the hospital. So you're right. Dig in, find what matters to the hospital, and then exploit that thing to be able to get what
exploit, that's a good word.
Yes. But
exploit for goodness.
Yes, right? Manipulation can be a good thing, right? That's a really good start. Okay, so that's how we pitch it to admin, but where do we even begin to start this? And how could we get the expertise of someone like you who has actually started a program and you've been doing this for a long time? How would we get it started at a hospital?
To be very honest, Gwenny, there are very few resources out there for rapid response teams. It's such a small but growing niche in nursing. And so I have personally had a very hard time finding education for that's specific to rapid response nurses. There's so much education about critical care nursing or ER nursing, but rapid response nursing is a different beast. It is a different kind of nursing. Leading resuscitation in a med-surg floor where everyone in the room is scared is very different than resuscitation in the ICU or in the ER where you're in an environment people are used to. Like emergencies are supposed to happen there. They're not supposed to happen on the med-surg floor. So there's so many, not just like science skills or like clinical skills, but there's a ton of software skills that rapid response nurses need to possess. And so as far as training for that, honestly, there's very limited. that's actually why I started my podcast is to like give those resources, not just to rapid response nurses, but also to the bedside nurse who calls the rapid response. And I've actually started doing consulting and education, like live in-person symposiums for hospitals that are wanting to equip their rapid response nurses because I couldn't find anything out there. Like when I started my team, I searched high and low for rapid response training for my team that I had just hired and literally could not find anything. I found one quote rapid response certification course and it was bogus. I'll be honest with you. It was like, the content was not specific to rapid response nursing. It was just this guy yapping for hours about not necessarily rapid response cases, just like pathophysiology in abstract form. But I wanted to know, like, when I show up and the patient has this and this and this, and this is the challenges we're facing in the room from a team dynamics perspective, like that's the stuff I really wanted. It didn't have any of that, which is why I've had to create it. So I do these rapid response symposiums. They are so much fun.
Tell me all about it. I want to hear every juicy detail.
I will tell you all about it. Yes. So I go into the hospital for a couple of days. The one I just recently did, I got to partner with their sim center. They have like an education sim center. And so I built all of these scenarios about real rapid response cases that I have had to go to. And so we would alternate back and forth between like an hour of didactic training and then an hour of simulation training. And the simulation training was not just like ACLS, you can get that anywhere. It was very specific to how to manage a rapid response. And it was so much fun because I had we would cycle through, everyone got to have a chance to go. So the rapid response nurse, they wore a red bandana. And the bedside team, which included the primary nurse, the PCT or like CNA, the charge nurse, they wore blue bandanas.
Okay.
But they had like cue cards for their personalities, their competencies, their lack thereof. And so not only does the rapid response nurse have to save the mannequin, they also have to respond to the challenges of caring for this patient with this particular team, you know, like the person who's not doing high quality CPR, the charge nurse who's like being very harsh and getting in the way and questioning everything you're doing, the bedside nurse who is scared and floundering, like those types of dynamics are things we face as rapid response nurses. And so it was almost like simulation training and comedy improv all mixed together as this scenario unfolded. So you have the patient, like the mannequin, and the vital signs are declining, and the rapid responders have to figure out why are they declining, what are we going to do about it, and also, what is that nurse doing? What is that nurse tech talking about? Like just managing those dynamics it was so much fun. I can't even tell you how much fun I had. I could have gone for weeks doing these scenarios with these amazing nurses. So yes, I love the opportunity to share my experiences and my stories to help another nurse feel more prepared for the next emergency they might encounter. You know, I've 22 years in the profession. I got a good share of experiences. And so I'd love to, share them with someone else so they're more prepared than I was for whatever happens.
That is so cool.
For example, one of the scenarios was a cardiac tamponade. My first cardiac tamponade patient, I'll be honest, Gwenny, I did not recognize it as cardiac tamponade. There was so much going on. There were so many pieces to the puzzle. I actually thought I killed the patient because I pushed Zofran right before they coded. I was like, oh my God, I thought it was Zofran, but what did I accidentally grab something else for the Pyxis? And that's why I was not computing that it was cardiac tamponade. I thought it was me. And so I used a very similar scenario with them to give them a chance to catch what I did it the first time. So I love it. I love rapid response nursing and I love teaching about it. And I really love simulation training. And these 2-day symposiums allow me to give very specific education to a team that's trying to level up the expertise that they can provide to their hospital.
That is so cool. What an amazing learning experience. So I am a learner by doing. And so being at the bedside, taking care of patients, that's where I learn the most, right? But that isn't always available, right? And so simulation, I think, is the next best surrogate for experience. You know, in nursing right now, we have, especially during COVID, we lost so many of our 30-year nurses, and those are national treasures. Having like a mom nurse on the unit, right, having a work mom, I know that you probably have one. I have a couple of kind of work moms throughout my career that have really impacted who I am as a nurse. And right now we're at like night shift at the ER, where I used to work at. I just recently resigned my ER position because I can't keep up with all of the working with my helicopter shifts and doing the education stuff. I had to say goodbye to my ER position. But on the night shift there, the most experienced nurse is on some night shifts is like maybe a 3-year nurse, right? And I find that that's true so many places, that especially night shift, we don't have that much experience. But I think that the next best thing for experience is putting nurses through simulation. And it sounds like you put together an incredible program for this hospital team that was starting a rapid response team. And I've heard you talk about so often in your videos and in your podcasts that one of the most important parts of being a successful rapid response nurse is having those soft skills. And nursing school doesn't teach us those soft skills. But on a med-surg unit, those are phenomenal nurses as well. Like, people kind of poo-poo on med-surg nurses sometimes, which I'm grateful I've never heard you do that either. But I am very impressed with med-surg nurses taking teams of 7 or 8 patients and getting all of those head-to-toe assessments. Listen, I haven't done a head-to-toe assessment since nursing school, right? I'm an ER and a flight nurse. I do a focused assessment, but they're able to do all of those things and manage. They're spinning so many plates at once with all of their patients. But when they are in an unfamiliar territory of a patient has exacerbated into a crisis state, right, an emergency, that can be very difficult for them. And so when any of us, whether we're talking about us as human beings outside of the job or in our nursing specialties, when we tiptoe into unfamiliar territory, we're almost always not our best selves. And so that's when we can let the fight or flight take over and we can panic, right? And we're not going to perform good medicine. We're not going to perform good nursing if we are in a panicked state. And so you, as the rapid response nurse, getting to step into that moment and you providing the calm in the middle of their storm, those are soft skills that nobody ever taught us, right? We kind of have to learn them on our own. So it sounds like this 2-day symposium that you have created for rapid response teams is really focusing on those soft skills, right? To become a rapid response nurse, you've got to have the experience. You've got to already know your pathophysiology. You've got to memorize all of that pharmacology. Like, the nursing, that's locked in. These nurses have that experience for that. But the training that it sounds like that's missing from the niche community of rapid response teams are those soft skills of conflict management, of reading people's body language and their emotions and providing the calm in that moment. And I love how you're creating these teams, and you're giving them experience to be on the other side of it, to pretend to be the panicked, med-surg nurse or whoever it is. Your patient has decompensated, so it gives them a taste of what it's like to be on the other side and what good experience you created for them. Have you heard back from that team? Like, have they sent you any reflections or anything after their time with you?
Always very positive reflections. Like, we weren't expecting it to be this much fun was a common thing that I heard. Like, I thought I was going to like an all-day class, but I would laugh so much. I learned so much. It was so much fun. And it really, really was a ton of fun. And also, that's what you said was exactly what I heard. This is the stuff I didn't learn in nursing school. This is the stuff that I've been trying to ascertain just through trial and error, but to hear it all put together in this polished production presentation was so, so valuable. And to be honest, this is stuff that's taken me 20 years to figure out myself. When I was in new grad, I didn't know how to do conflict management and to read the room and bring calm to the chaos. I knew task, I knew the ACLS algorithm, and I could carry it out. But as far as all the other stuff, I did not know that. I learned it, one, from screwing up and be like, well, that didn't go very well. And also watching other people doing it both wrong and right. There were charge nurses that I looked up to so much because of their ability to manage the room and manage the chaos. And there were charge nurses and physicians that I was like, oh my God, that is not how you do that. That wasn't very effective. It felt icky in the room when they acted that way. And I think to myself, oh, well, I will not be doing that again. And then even my own reflection, on the ride home from work, I'm thinking about the code I had and I said this and the person responded this way. Maybe I should have worded it this way. I could tell it put them off. I could tell it made them feel uncomfortable. Just reflecting on my own behaviors and compiling that down into very specific application for how to respond to not just the patient's emergency, but the staff's emergency.
Hey guys,
I'll get back to the show in just 1 second, but before I do, I have a request. If you have ever gotten any value from this podcast and you want the show to continue to grow, to access more awesome experts in the field, and to keep providing you with more nursing knowledge and inspiration, could you take a minute to leave a rating and a review? Those reviews on Apple and Spotify go a long way in getting this podcast in the hands of more nurses and bringing new guests to the show. And they just make my day to know that my stories and nerdy patho breakdown are helping other nurses thrive, or at least survive. So if you're feeling up to it, I'd love to see a rating and review from you. Thank you so much. Now back to the show.
So let's pivot. You gave me kind of a good idea for a question. Are you in charge of hiring of your own rapid response team at your hospital?
Mm-hmm. Yep.
Do you ever interview very smart nurses, very strong candidates on the pathophysiology side, but maybe you find that maybe they're a little too brash or too aggressive? And how much does that play into whether or not you hire a candidate who wants to be on the team?
That is a huge factor. So at my hospital, we require 3 years minimum of critical care or ER experience and certification in your specialty. So CCRN or CEN. So these nurses at minimum have passed a really hard test and been at the bedside caring for critical patients for 3 years at minimum. Most of them have much more than that. But I'll get some applications that like the resume is super impressive. They have all the letters behind their name. They've worked at this trauma center and this type of ICU, like all these like cool stuff. But you meet them in person, you're like, I think I'd be afraid to call you. Like you seem a little brash. You seem a little cocky. And those are things that they seem like, oh, of course they're cocky. They've been a nurse for 15 years and they have all these accolades. Of course they're cocky. But if that comes across to the bedside nurse, I see that as a handicap because it's actually going to prevent future patients from getting early activation of the rapid response team. You know, like nurses are afraid to call this super experienced nurse because the way they carry themselves, that means the patient will decline more. And so personality is a huge part. Let me tell you a couple examples. So whenever I was just on the rapid response team, but not actually on the hiring, I wasn't in charge of hiring. I was just doing like peer interviews. We were told, hey guys, we have someone coming in to interview today, peer interview. His name is blah, blah, blah. Just let you guys know, we're doing the peer interview at 3:00. So of course we like Facebook stalk this guy. Like, who is this person that's interviewing to be a rapid response nurse? And his very last post was something along the lines of like, 6:59 code blue day shift problem. I'm out. That was like his Facebook post. Oof. And all of us were like, that doesn't really fit with the vibe of someone who's supposed to be coming to the rescue of crashing patients. Like, I get it. Like your shift ends, and yes, you do have a right to like pass off to day shift, but we're looking for people who like are stoked about responding to code blues and supporting the patient and the team and not being like, I'm out, you know?
Yeah.
And so that interview, I think he could probably tell from very early on we were not interested in hiring him. And honestly, that was his personality. He was very cocky. He thought that like, he was almost like too cool for bedside nursing. We're like, yeah, no, you're not gonna, not interested.
Ooh, no. Even just hearing you tell that story gave me a yucky feeling in my belly. Like I would rather work with a teammate who maybe isn't as clinically strong, but has a phenomenal attitude than to work with someone who is an absolutely brilliant clinician, but is just a crappy human being. Like, I think if I could pick one thing that drives me nuts in nursing more than any others, it is the attitude of not my patient. Not my patient, right? 6:59 day shift problem. And you're right. Yeah, we do have to have healthy boundaries, right? We don't want to be staying until 9:00 if that code is, that patient, we get ROSC and then, that we have to work really hard to keep them alive, right? It would be ridiculous to stay that long, but we have to have a willingness to do the right thing for the patient, whether or not it's our patient. There's air quotes for listeners who could, my patient, or really all of the patients. When I'm working in the ER, I consider all of the patients in the ER are my patient because we're all sharing the responsibility of making sure all of these patients get the care that they need.
a couple years ago, we had a position open. And so, people applied. It's a very coveted position in the hospital to be a rapid response nurse. So
Yeah.
great people applied, very qualified candidates. One person in particular, they'd been a flight nurse for many years. They had multiple certifications, ER background, like on paper looked great. And in the interview, I always ask, like, tell me about your current job, like your current role. What do you love about it? What are some things that are challenging about it? And the response is basically like, flight nursing, it's a bunch of, pardon my French, bunch of bullshit. There's so many bullshit calls that we get that I'm like, this is so dumb. Why would you even call us for this? And he's like describing this to me. And like, I get it. I hear you. You see yourself as a flight nurse. You think you should only be responding to like the most elite emergencies or whatever. I know that's how you see yourself, but like that tone of like, this is a bullshit call, I know that's going to carry into how they respond to rapid response calls. And I cannot allow that. I cannot allow the culture to shift or like plummet to that level, because the bedside nurse is going to feel that. And again, like I said, they won't call next time. So this nurse on paper, I was like, oh, we got to hire this person. They seem amazing. But then I brought them in the office. We got to talk and I was like, yeah, I'm sure they're super fun. I bet they would not let any patient die on their watch. Like, I'm sure clinically they're stellar, but there's so much more to it. I ended up interviewing another nurse. She had been a nurse for only 5 years. He had way more years than that. Only 5 years, ER nursing, but man, her heart was for nurses. And she was like, I love precepting. I love when I have new grads. One of my favorite parts of being a nurse is getting to show another nurse how awesome this job is. Thinking about going to education, like what kind of education do you do as a rapid response nurse? I heard you guys like round with the crash cart. Like, could I be a part of that? I was thinking about maybe coming up with like classes or like, she was so excited to like support other nurses. And I was like, you know what? Your resume is very brief. You've only been in this for a little bit, but we ended up hiring her over other more experienced people. And she actually just won Nurse of the Year, Rapid Response Nurse of the Year this past week.
So cool.
She's done amazing. So yes, I definitely look for not just clinical competency, and our Nurse of the Year definitely has clinical competency, let me tell you, but also just like their approach to the patient, their approach to the bedside team, how they can interact with the interdisciplinary team. All those skills are ones that make us effective. It's not just about, can you follow the ACLS algorithm? There's so much more to rapid response nursing.
Yes. Yawn, boring. Everybody can follow an ACLS algorithm, right? But oh my gosh, that actually gave me goosebumps when you were talking and you said, I cannot allow that. Like, you went into mom mode there for a second, like your voice got stern. and I love that you are so protective of what you have created at your hospital, that you have taken ownership because you care so much about the bedside nurses and making sure, like, I think about how many times, and I've been doing this for 12 years, how many times that I have sounded the alarm bells and gone to the ER doctor and said, oh my gosh, we've got this patient in room 5. I think they're really sick. I need you to come see them right away, right? And the doctor comes to the bedside and they're coming with the mindset of, oh, this is a super sick patient. And they get there and they're like, oh yeah, that's no big deal. It's just XYZ, right, whatever. And then I feel like a ding dong dummy head, but I'm better at figuring out who's actually really, really sick now than I was 12 years ago. And so, maybe it's a med-surg nurse who has only been a nurse for 6 months. And so she has never seen a patient in XYZ, whatever it is. And so if that nurse sounds the alarm bells and calls a rapid response, and that bullshit flight nurse comes to the bedside and is going to belittle that bedside nurse, and that's going to leave them with a bad taste in their mouth. So we have to give, especially newer or inexperienced nurses, permission to get it wrong from time to time. I still get it wrong after doing it for 12 years, and I have a whole slew of advanced certifications and quite a bit of experience. Like, I still get it wrong sometimes, right? I had a case like maybe a year ago in the emergency department. And I was working in we have like a super sick pod and then like a medium sick and then fast track. And so I was working in the medium sick kind of area of the ER. And I had a patient come in that was abdominal pain, which is like the most common complaint that we get. And I was just sure that this patient had an ovarian torsion. And I knew that the nurse practitioner who was working fast track in kind of medium sick area had just been loaded up with like a bazillion patients, right? And I knew it was going to be like an hour probably until she got to this patient with an ovarian torsion. And listen, that one really pulls at my heartstrings because I've had ovarian torsion twice as an adult. And so this is one that like I don't mess around with. So I went over to the super sick side and I grabbed one of the ER doctors who I have a pretty strong relationship with. And I said, hey, I've got this patient in room 19 and I know it. I feel it in my bones. She has an ovarian torsion. I need you to come see her right now. And he was like, absolutely, I'll be right there. He came down and saw her in like 30 seconds, ordered the ultrasound, allowed me to give her some really strong pain meds to control her pain. I mean, she's just writhing. The patient cannot hold still. And I just knew it. I was so sure that she had an ovarian torsion. We get the ultrasound back and it was just a simple cyst. And I felt like such a ding dong. And I was like, Gwenny, how could I have gotten that wrong? But all that to say, like, we all get it wrong from time to time. And the measure by which we judge others is going to be the same measure that is used on us. And so I would rather be met. And the doctor, I felt so silly. And I went to the doctor and I was so apologetic. And I said, I'm really sorry I pulled you down and made you pick up an extra patient. Like I was wrong. I'm really sorry. I was really confident that that was a torsion. It's just a cyst. She doesn't need to go to the OR. And he was like, slow down. You're fine. It's okay. I appreciate you advocating for that patient. So you were wrong this time, but maybe next time you're probably going to be right. And so I really appreciated that graceful response with him. And so that's how I want to respond to others as well. And it sounds like you definitely hired the right person when you had the choice between, the bullshit flight nurse who was going to, be upset when it wasn't right. But we have to give nurses permission to get it wrong because that's how we get better at getting it right down the road.
To your point, like, you didn't do anything wrong for advocating for a patient in pain. You were trying to expedite them getting care. They were clearly in pain. That is the right thing to do. Maybe your diagnosis was wrong, but your gut instinct to advocate for someone in pain was totally right. And so when nurses say, hey, I'm so sorry to call you, but I just feel like the breathing is just not right. I always say, the breathing's totally fine. I always say, thank you so much for letting me know. Thank you so much for being concerned about your patient. So here's what I'm saying. That type of respiratory pattern is very normal for this, and this, and this. Like, whatever. I explained the reason why I'm not concerned, and I thank them for letting me know. And I'm like, however, you're onto something. If your gut says something's changed in your patient and you see X, Y, and Z happen, that tells me they're declining in this way. Call me back. And then I have the benefit of having a baseline of this patient. I know what they were like hours ago. And then if they do decline, I'm like, oh yeah, this is definitely different than what we saw before. So my approach is not to be like, oh, well, this is an emergency. Everything's fine and walk away. Instead, I say, wow, thank you so much. All right. Well, I feel okay right now because of X, Y, and Z. But if something changes, and let me tell you, very often things do change. The patient was okay.
Yeah.
And then they're not. Like that, as far as intuition goes, and I don't have a good science behind this.
Yeah.
But I feel like there's something that happens when you're physically with a patient.
Yeah.
That allows you to tap into something deeper than just their physiologic assessment findings. And so these nurses, especially med nurses that have had patients for 4 or 5 days. Like just last week, I had a nurse, she had a patient over the weekend, then she was off for 3 days, and then she came back to the patient 3 days later, and she called me like, hey, this was not the patient that I had a couple of days ago. This is very different. I don't know what is wrong, but something is wrong. That patient died that day. Like she knew it and the vital signs were not reflecting it at all. And so even though clinically I'm like, well, he's talking to me, he's pink, he's warm, he's dry, vital signs are okay at the moment. But she's like, no, I'm telling you, he doesn't breathe like that. Like he is different. He seems more confused. Like she knew something was up because she knew the patient. And so I have learned just to trust that. Like I have the benefit from resuscitation of coming in without any foreknowledge. I don't have the emotional burden of we have to save my patient because I met their grandkids, I don't have that burden, but I also don't have the benefit of knowing this patient's baseline, knowing what they usually act like. And so I had to defer to the expertise of the person who knows the patient. And I've learned so many times that nursing intuition, listen to it. And so I see myself more as a colleague, a comrade. We're on the same team, me and the bedside nurse. So if they're concerned, I am now also concerned, rather than step aside, rapid response is here to save the day and tell you if you're dumb and tell you. I'm I talk to nurses. I feel so bad. Before we had a dedicated team, there's one particular charge nurse. They're no longer at our hospital. That was just known for being condescending. And nurses told me I was so afraid to call because when I called for a patient, it was one of two things. Either this is dumb, why'd you call us? Or this patient's sick as shit. Why didn't you call us already? Why'd you wait so long to call us? She's like, you literally could not win with this charge nurse. They all, no matter what, they would make you feel dumb. And so none of us wanted to call. We hated calling rapids because it's like a lose-lose situation. You didn't do a good job for calling because you waited too long, or why did you call for this? It's dumb. And I was like, oh, I'm so sorry that's your experience. You will never hear that from me or from my team. That's not helpful for anyone. So we worked really hard to shift that culture, and I would say we have. So I'm proud of that.
Excellent. I think you really hit the nail on the head when you said we're all on the same team. I said earlier that not my patient is my biggest nursing pet peeve, but probably the second one is the us versus them, right? I don't consider it, when I'm working in the emergency department, I'm trying to report upstairs, and they'll say, hey, that nurse isn't available right now. Can they call you back in 5 minutes? Inevitably, and Sarah, this as an ER nurse, what happens as soon as you hang up the phone? Yeah, they said that nurse isn't available. Yeah, right. They just don't want to take a report on the patient. Like, no, I got to check myself and make sure I don't have that attitude, because as a med-surg nurse, they have 8 patients up there and I'm getting ready to send them another admission, or they're trying to discharge someone to make room for my ER patient. And it's not us versus them. I see it a lot in the ER as like EMS versus ER, where, maybe the charge nurse gives the paramedic a hard time when they bring a patient in, or they'll say, oh, why'd you bring that patient here? Well, because we couldn't take them to Quick Trip to have an EKG. Okay, so we're bringing them to the hospital instead. We have to all remember that we're all on the same team, and that team is team good patient outcome, right?
Yes.
And so we all have to work together and support each other. So I love so many of the things that you said. Thank you for sharing your wisdom with the listeners today, sharing some of your experience that you've had starting a rapid response nurse, of advocating to create this program within your hospital. And now you are extending that out to other teams that are trying to get started with your consulting and the training that you're providing with them. Thank you so much for sharing all that. I know I learned stuff from you today, but I want to give you an opportunity. Is there anything that you want to leave the followers with that you feel like would be beneficial for them to hear at the conclusion of today's podcast?
A couple things, and I'll talk to a couple different audiences with it. Number one, trust your intuition. I'm sure if you listen to my podcast, you've heard me say that phrase a gazillion times because I really feel strongly about it. I think the biggest lesson of my first year as a nurse was to listen to that. There's so many patients where I thought they were not doing good. My gut system was up and I didn't listen because I didn't have data to validate it. But learn to correlate that intuition with what you're seeing in your patient, and eventually it'll make you a better advocate. And that's thing number one. And thing number two, you kind of already said it, Gwenny, is that we're all on the same team. I've had the benefit of working both as an ER nurse and as an ICU nurse, and now as rapid response. I get to work elbow to elbow with some amazing med-surg nurses, PCU nurses, OR nurses, IR nurses, like all the different specialties in my hospital. I get to work alongside them. And honestly, we all have the same struggles. And so no one benefits when we are up against each other. Yeah, but everyone, including the patient, benefits when we can work alongside each other and support each other. Like, I can't think of any benefit of bashing another team member. And I get it. I get the funny stereotypes about ER nurses versus ICU nurses versus med-surg nurses. I am the stereotype. I totally get it. But at the same time, to say things negative about their character, that's the part that I have a hard time with. And so if you can find ways to be understanding and give grace to the different types of specialties and the challenges they face, or just ask them, what are the challenges that you're facing in your unit? And not just assume you're the only one that's having a hard time on your shift. I think it makes us better as clinicians, and we can give the best care of the patient. In fact, how amazing is it when I can tell a patient, hey, I'm moving you to this room. You're in good hands with this nurse. Or I'm calling a report to, Gwenny, I know her. You're in good hands with her. How affirming is that for the patient, rather than just assuming that it's going to be bad because it's this particular environment or because it's an ICU nurse. I mean, that particular personality. Not necessarily. There's all types of personalities everywhere, and we're all here for the same reason as for the patient. So those are my two takeaways. Give grace to each other and trust your gut.
Excellent. I love it. Well, Sarah, thanks so much for letting me do a gentle podcast takeover. And it was really
so
great.
Gentle. Yes, thank you.
It was really great learning from you and letting the listeners learn a little bit of your perspective as well. Listeners, thanks so much. We'll see you on the next episode.
Awesome. Thanks, Gwenny. Bye. Hey guys, this is post-production, post-editing Sarah, just chiming in really quick. I wanted to say how much I just love Gwenny. She has become a true friend in this whole online critical care nurse educator world, and she is a genuinely kind-hearted, generous type of person who constantly pours into others, and I truly want to support and promote everything that she does. If you didn't know, she created something called the Nurse Gwenny Library. It is packed with hundreds of incredible courses, both short form and long form, where you can earn CEs in a way that's actually engaging. Not only does she have her own amazing content, like her flight nurse courses, but she's also partnered with other great educators like me to create learning experiences that aren't just death by PowerPoint hospital modules. A ton of my podcast episodes are already available on the Nurse Gwenny Library. So if you already listen to the podcast, you can actually earn CE credits for your time by checking it out there. If you want more information, I'll put a link in the show notes for you. And finally, if you are a rapid response nurse or nurse leader listening and you'd like more training or support for your rapid response team, please reach out to me. I would love to hop on a call with you and talk about how I can support you and your team. This is truly my life's work and one of my favorite things to talk about. So you can email me at sarah@rapidresponsern.com. Thanks for listening today. This was so fun.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.